that in the brachial clefts there's a series of openings, and as they close off, sometimes the cleft doesn't completely close, and then you get this pouch that develops. The difference between this and it's kind of the same thing. They have an upper respiratory infection, but then they get a neck mass that's lateral. So brachial cleftis is a lateral neck mass. It's really soft. It's usually not tender. They just feel this lump in their neck. If there's some tenderness with it, you have to think of a secondary bacterial infection. These patients would get a CAT scan, and that CAT scan, when the radiologist would usually be able to tell us that it looks like a brachial cleft cyst, and we just take those out for surgery. So viral glossal duct cyst, think midline; brachial cleft cyst, think lateral neck. Sialoadenitis is an inflammation of the salivary glands, so either the parotid glands that sits here or the submandibular gland that sits underneath the jaw. We talked earlier about the Stinson's ducts. That opens up into the cheek and drains from the parotid gland, and then the Wharton's duct, which sits in the floor of the mouth. Usually now when these get infected, they're bacterial, because viral would be mumps, and we don't see mumps anymore as long as people keep vaccinating their children. But most common is staph, strep pneumo, and H. flu. So the most common is staph that you see here. So you have bacteria inside of the mouth that goes inside of the duct and gets into the salivary gland, and then they get infected. That's how it works. People that are prone to that happening are patients who, this is a little out of order, but the more common thing is dehydration. Sjogren's syndrome was that autoimmune syndrome I talked about earlier that can cause dry mouth and parotid swelling. Diabetics, alcoholics, medications that cause, because our saliva should drain from the parotid gland through the Stinson's duct inside the mouth. So any medicines that's going to cause the saliva to pool in the salivary gland and not drain out, like diuretics, will make the saliva thicker. Anticholinergics make the saliva thicker. The saliva just kind of stays there. You get bacteria that goes into that duct, and that causes infection. So acute onset of pain, swelling under here, under the submandibular gland, or in the parotid gland. Sometimes fever. I usually don't get a CBC on these patients, but they would have leukocytosis if you did. And then if you actually massage the gland and looked inside of their mouth, you could see pus draining from the Stinson's duct. Or if you massage here, you may see pus draining from the Wharton's duct. You put these patients on antibiotics. Remember I said oral, Augmentin and Clinda are my top two. That's why I would put them on one or the other. If they're allergic to penicillin, just use clindamycin. I would have them massage this gland, heating pad, increase hydration, have them suck on lemon drops or lemon candies that will help stimulate the saliva to come through the duct. So sialoadenitis, more common in the submandibular gland, less common in the parotid, but it can happen. So there's that looks like a large stone on the left floor of mouth. And then the right side is the Stinson's duct. You can see how it looks inflamed there. And if you massage that gland, you may see pus coming out of it. That is just an aphthous ulcer, and then your Stinson's duct is right next to it. That looks like somebody that dips tobacco or chewing their teeth, but you can see that little pouch there just below that molar, that little bump. That's the Stinson's duct. That's what sialoadenitis looks like. So that's usually painful and tender, and they make up a fever. If you got an x-ray, you maybe you'll see a little stone there. I don't think that you have to get an x-ray. If you just feel that mandibular gland and it feels swollen, or if you just put your finger inside of their mouth and feel along that duct, you may be able to feel a stone. Yes?
Where's the best place to massage these? On the outside or inside?
Oh, sorry, outside. So when you're massaging, you're just massaging right here or down here. And you really want to massage it forward because you're trying to push that thick saliva out of that part. So I don't get x-rays, but those are good just to see it's a calcified stone. So that's why it's radio opaque, so it shows up on an x-ray. Sometimes patients are just prone to getting stones. I mean, the stones will, so you can get infection, like I said, but then you can also get little stones that block the ducts from draining properly. Kind of like kidney stones, but in the salivary gland. People that have these are usually patients who are on diuretics or diabetics, or they don't drink any water. Sometimes we have to take out their entire submandibular gland because you can't get, there's patients will have 10 to 20 stones in their submandibular gland. Again, the submandibular gland is the most affected, 80% versus the salivary gland, the parotid duct here is only about 20%. So, and I kind of went through this already, but anything that's going to cause change in the salivary secretions like dehydration, sometimes the ducts become narrowed, that can lead to infection of the gland. Sometimes, just like kidney stones can pass, these can pass as well. They can pass through that Stenson duct if they're really tiny. So if you do the massage, lemon drops, heating pad, increasing saliva, and maybe they're not feverish, but they have a little stone there, they may just pass it just like a kidney stone. Sometimes I've had to take one of these out in the office. You just make a little incision and pop out that stone and take it out. But if you try all those things and they still have a little stone there, you just send them to us and then we can take care of it, or send them to an ENT. Swallowing and dysphagia. So dysphagia is difficulty swallowing. There's different types of difficulty swallowing. It can be because of a mass in the oral pharynx. It can be from a muscle problem where you have a motility disorder, narrowing in the esophagus called esophageal stricture or an esophageal web. Those are narrowing in the esophagus. Sometimes it's caused by people that have chronic severe reflux, people who are alcoholics. Sometimes cancer can cause it. I think we'll skip over. This is just kind of a workup. I'm going to skip through this just because what I think you need to know about dysphagia is people with dysphagia, it can be from reflux, it can be from an esophageal stricture, a motility disorder, esophageal web. It can be from numerous things. What you do to work these patients up, I see them and I say, I don't know what's causing your difficulty swallowing. We need to do something to figure that out. And so you can get a test called a dysphagogram, where a speech pathologist will have the patient swallow liquid, pills, tablets, foods. They actually take radiographs or x-rays while they're swallowing. And they coat that in a barium and they watch them swallow it, and it will tell us exactly what the problem is. So you can go through this whole algorithm, you know, looking for stuff, but really what you're just doing is you get a swallow test and then try to figure out what it shows and you go from there. If it's a stricture, and this is kind of off the slides, but if it's a stricture, we can actually go in and stretch and dilate the esophagus. If it's a severe reflux, we put them on a PPI medication like Protonix or Prilosec. If it's a web, which is basically a scar tissue web that's crossing across the esophagus, we send them to GI. So you might learn more about that in your GI lectures, but from an ENT perspective, that's what I do. Barrett's esophagitis. I don't see this very often, but basically for patients who have chronic GERD, and this may be a test question, but specialized columnar epithelium replaces a healthy squamous epithelium. So instead of it being squamous epithelium, it changes to a columnar epithelium, which then is basically a metaplasia or dysplasia of the esophagus. This can be related to chronic reflux, people who are alcoholics that just change that tissue, and it usually leads to adenocarcinoma. Most common cancers in the voice box and the head and neck are squamous cell carcinoma, and the esophagus and the bottom 2/3 is adenocarcinoma. So upper 1/3 of the esophagus and larynx is squamous cell carcinoma, and the bottom 2/3 is adenocarcinoma. People can have Barrett's esophagitis and it not develop into cancer, but these patients have to be on a PPI or a proton pump inhibitor like Prilosec usually for the rest of their lives. And they have to stop controlling the reflux, they have to control the reflux and stop alcohol. But there is a chance that Barrett's esophagitis can transform into an esophageal reflux. So GERD, people, if you have a patient that comes in and they have painful swallowing, which is called odynophagia, that is cancer until proven otherwise. So, obviously, like I said before, twice, treat the reflux, because that's the predisposing factor. If they have symptoms of GERD for more than 5 years, they're an older patient, and they're having some dysphagia, you should just refer them for an EGD, which stands for esophagogastroduodenoscopy. So it's a scope exam, you're kind of put into twilight sleep. Not us, but usually a GI doctor will go in, look through the mouth, go down into the esophagus, and look for anything that they're able to look, take biopsies, they can dilate the esophagus at the same time. So remember before when I said whenever I get someone with dysphagia or difficulty swallowing, I refer them for that dysphagogram. Well, if I have anybody that comes in complaining to me that they have painful swallowing, and maybe they're a smoker or they're drinking a 12-pack daily, I just go straight for a scope because I'm really worried about it being cancer. And if they do a scope, like with an EGD, they can just biopsy it at the same time. Okay? So that's more like a real world no. But if you're going to evaluate someone for dysphagia, the first line is dysphagogram. The second line is an EGD, just because it's more invasive. But again, if I have someone with odynophagia, I'll go straight for an EGD. Disorders of the larynx. So larynx is the voice box. The bottom picture is really the best picture to look at. So you can see the vocal cords. This is looking at, so the very top is the tongue, and then you have the epiglottis, and then the vocal cords, and then where the esophagus is at the very bottom. So this is the vocal cords here. That we can see. And whenever I see patients in the office, for hoarseness, I can do an exam where I look in their throat with a mirror. I can also do a laryngoscopy where I spray their nose with numbing medicine, and I actually use a little camera that goes through their nose and looks all the way down to the vocal cords. It usually takes me like 30 seconds to do it, but it's a really great way to look at the voice box. So if you have patients that are hoarse, they're a smoker, and their hoarseness is lasting more than a month, you should refer them to an ENT to be scoped, because they could have cancer. But this is a normal vocal cord, should be white. This is when someone's breathing. When someone's talking, the cords come together and they vibrate off of each other and they produce sound. That's what I do in the office a lot. Those are called flexible laryngoscopies. So the functions of the larynx is obviously protect the lower airway. So when you swallow, the food goes down, the vocal cords close, so food can't go in between the vocal cords. Obviously helps with phonation, it gives you your voice, and also with breathing. Oh, this is like a frog in the throat. There's actually patients with laryngitis will say, I feel like I've got something stuck in my throat. So that's what happens. Laryngitis is acute inflammation or infection of the larynx and the vocal cords. Patients will usually come in and they'll have an upper respiratory infection. They lose their voice, they have a sore throat, it comes on suddenly. Again, it can be bacterial, it can be viral. They've smoked, they've been to a party and they've been out screaming all night at some concert. That can cause a laryngitis. Usually it's just self-limited. You don't have to do anything. Just give it some time, it'll go away. It says less than 3 weeks. Usually it's about 10 to 14 days. Put them on some voice rest. Just tell them, don't use their voice. If you suspect bacterial, usually patients, they have a low-grade fever, they may be coughing up some really yucky yellow stuff. In my office, I would scope them and look to see if I can see anything. In the real world, you would just have to kind of go based on their symptoms. Like if they're hoarse and that's it, then don't treat them with it's very rare that I would treat someone for bacterial laryngitis. Chronic laryngitis is usually if it's going on for more than 3 weeks. So usually those are in smokers. If you notice, you hear those people with smokers' voice, you know, it's because their vocal cords are swollen and they don't vibrate as well as easily off of each other. Asthma inhalers, so like those inhaled steroids can actually, like Advair, they can cause yeast on the vocal cords. And so that can cause a hoarse voice. Just like, you know, steroids, if you use them on the skin, they can cause atrophy of the skin. If you use topical steroids in the throat, you can get atrophy of the vocal cords. So the vocal cords will thin out and they won't come together as easily, and then you'll get a hoarse voice. So if you just get rid of the steroid, give it a few months, patients will usually have a return of normal voice. So an indirect mirror exam, so acute and chronic laryngitis, it's based on symptoms, like I said earlier, so dysphonia, which means a hoarse voice, sometimes difficulty swallowing, odynophagia, like I said, I worry more about tumor, sometimes some difficulty breathing if their vocal cords are swollen, and then they have kind of that viral prodrome of postnasal drainage, sore throat, and congestion. We can actually, and then the flexible nasal laryngoscope is what I was talking about that I do a lot. You can actually do a mirror exam. I don't know if you learned that in physical diagnosis, but you can actually grab their tongue, put a little mirror inside of their mouth, and shine a light off of that mirror and look down their voice box. It's kind of hard to visualize that, I know, but it's a good way to look at the voice box. Acute laryngitis usually lasts 7 to 10 days. If it's longer than 3 weeks, like I said, you need to refer them to an ENT. Voice rest, stop smoking, use a humidifier. Those are really the best forms of treatment. You can't put them on really steroids or antihistamines. So you can see like the bottom picture of the normal vocal cords, and that looks like somebody that's had a viral laryngitis or overuse of their voice. You can see on the top right picture, they've got some inflammation there. That still looks like viral. And actually that picture in the middle where he's using a mirror to look down the throat, that's the indirect mirror exam I was talking about. That's a very challenging technique, and it took me like a year to learn how to really do it well. So you wouldn't do that unless you're working in ENT. Oh, that's it? Oh my gosh. That was really fast. I thought I was going to do more. Okay, what questions do you guys have?
I heard someone say that there's like a lot of risk with intubating, like that it's common for people to really mess that up. Is there truth to that, or?
Well, sure. I mean, that's why you want someone, especially in an emergency setting, that's trained in intubation. So for patients, or for people who are not well trained in that, sure, you could hit the vocal cord, you could cause a vocal cord paralysis, you can, where the vocal cord just quits working, you could cause a vocal cord granuloma where it bleeds, or a vocal hemorrhage. So yeah, it's something that definitely, you know, you need to be well trained in it, because it can certainly cause some risk to it.
What do you do if someone gets something stuck in their throat, like in a pouch, not where they can't breathe, but how do you
Like
take
a
that
foreign
out?
body?
Yes.
If they've tried to, obviously, if they've tried swallowing, like if it's stuck in that cavity on each side of the voice box, and you can't get it out, we'd just usually, if it's a foreign body, sedate them, take them to the operating room and pull it out. There's really not anything you can do in the office to take them out, unfortunately. If it's a kid and it's a foreign body in the airway, emergency room. In an adult, it's really just emergency, put them to sleep and take it out.
Do you use Centaur criteria to rule out strep or Centaur?
I don't, because honestly, I'm sure family medicine docs do, but I see strep whenever patients are coming in needing a tonsillectomy. So the criteria, I don't use that honestly very much. But if you're working in family medicine or emergency or urgent care settings, then absolutely. Anything else?
Do you say that a gonococcal pharyngitis will look like strep? Or
It kind of has more of a gray appearance to it, but it has a similar symptoms. But it's more of kind of a gray exudate as opposed to a white exudate.
You talked about uvula removal, if it's too long it's causing, would they be at an increased risk for choking?
No,
Okay.
not at all. Because the uvula really serves a little purpose. As far as choking, you still have a palate, so you're not getting rid of your gag reflex or your choking reflex. So, low likelihood of that causing that. Anything else? You guys hungry? Well, thank you for paying attention. You all have amazing questions. Like, I'm super impressed by the questions all asked. Hope it wasn't too boring. I feel like I flew through this. And I'm thinking right now, like, there's so many other things I should tell you guys about, but, you know, if you have questions, my name isn't on the slides, but let me just give it to you, and I'll give you my phone number, so if you have something that comes up in the future, you have some questions, you can always call. But Jamie, and then J-A-M-I-E, and then last name is Edminston, E-D-M-I-N-S-T-E-N. And then my phone number is 405-207-6169. And then my email is Jamie, same thing, Jamie, but hyphen Edminston at OUHSC, like OU Health Sciences Center, OUHSC.edu. So if you think of something, or later on you have a patient that you have some questions about, just certainly I'd be happy to help out. All right, thank you.
Thank you.